last career development seminar for the year. So I hope everyone's doing well and staying safe and productive. And I wish you a wonderful holiday season, in December and beyond. So today we're really fortunate to have Dr. Jake Pry to share some perspective around global research and his experience. So I'll give a very brief introduction and then we can get started. And Dr. Pry, I think the format is, we will have you speak for about, 35, 40 minutes, and then leave time for reflections and Q&A. Okay, great. So Dr. Jake Pry is an assistant adjunct professor in public health sciences at the University of California, Davis School of Medicine, and a senior researcher at the Center for Infectious Disease Research in Zambia. His research focuses on infectious disease epidemiology with an emphasis on HIV care cascade optimization, HIV non-communicable disease comorbidities, and implementation science in resource-limited settings. His domestic work has concentrated on COVID-19 research, including vaccine effectiveness, mask efficacy, and vaccine uptake patterns. And Dr. Pry earned his PhD in epidemiology from UC Davis in 2019, completed his postdoctoral training at WashU School of Medicine, and also serves as an instructor for multiple epidemiology courses at UC Davis. His extensive publication record demonstrates expertise in mixed methods research, program evaluation, and training evidence into practice to improve health outcomes in both low and middle income countries, especially Zambia and the United States. So it's a pleasure to welcome you, Dr. Pry, and I'll turn the floor over to you.
Thanks so much. I'm going to call you Dr. J because that sounds awesome. I'm so happy. Thank you for the invitation to be here. I'm thrilled to get to chat with you all. I've been in global health for a little while now, and I'll go ahead and start my slide deck here for you all. And I know you have kind of an understanding of I don't, if people have questions along the way, I'll try and monitor. If you've got, raise your hand or use that function or just talk, however we, want to do it. I'm not sensitive. I'm an academic, but do my best to try and not be a total narcissist. That's a battle. But I'm really thrilled again to be here with you all, to chat through some of my experience, California, Lusaka, back again. And then I think there's also a little bit of a push to kind of look at funding and talk a little bit about funding and what that looks like, at least from my perspective. Um, like Dr. J said, I am an assistant professor, just got reviewed for associate professor. So I'm hopeful that will move forward pretty quick. But that's where we are. So I'm gonna treat this like what I know best, which is kind of a paper outline. We're going to go through background, methods, results, discussion, and conclusions. Would love to hear any questions that you all have. So again, I got to walk through my background, how I got to where I am, and then what I'm doing now a little bit with research, and then how I'm funding what I'm doing also. With the caveat and disclaimer just ahead of it, there are many, many ways to be successful in global health, I think. And some of the most interesting folks have the most circuitous paths that you wouldn't think, would land them in a successful global health role, but it happens all the time. So this is just a story about how someone could be moderately successful in global health, using just kind of me as a template here. So background is lots of school. I'm from Texas. Don't hold that against me. I promise I left as soon as I could. And I went to Texas A&M University for my undergrad. I did biology genetics and then went to the School of Public Health there and did epi and biostats. And then went over to Zambia after I did my MPH, kind of fell in love with doing work in that setting, came back and did my PhD at Davis and then did some postdoc work at WashU. So my background and kind of love for global health sort of started with the Zambia Emory HIV Research Project, or ZERP. Some of you may be familiar with. Um, this is Dr. Allen, at Emory, has been working with couples testing and counseling for a long time now in Zambia. And anybody who's not familiar with that project. And it's also connected with RZERG, which is they have some projects going in Rwanda also. Um, if you're in kind of HIV research space and curious about Rwanda or Zambia, I would definitely recommend Dr. Allen's lab. I think they still have quite a bit going on. So, I mean, I think a lot of you here are kind of, you've already sort of drunk the Kool-Aid, so to speak. It's a horrible cliche, but um, you're into global health. Not an accident that you're here. You've done the time, done the work to be here. And to to be funded to do some work in international global setting. So and I know a few of you have worked in Zambia before, and one is my postdoc is actually in Zambia now. So you kind of get that. You've done the doctoral work, all that's great. Um, I think hopefully you're kind of getting some experience now to find out whether or not you do indeed really love it. It's for you. I think oftentimes global work can be fairly polarizing. You either fall off one side of the fence or the other. There's few that are unsure about it, and in my experience at least, I loved it. Um, but decided I needed some more training. I heard this very often, and some of you in sort of a postdoc, place may have also heard this. I was pretty terrified early on to be the HIV person or be the rotavirus person and I kept getting the same kind of thing. You got to go deep to go wide. So most of you probably heard that, and I fought against that for far too long. It is true at the end of the day. Um, I'm not trapped. I now get to be sort of a methodologist and work across lots of different spaces. It was good to be a part of CIDRS, is the Center for Infectious Disease Research in Zambia. It's a well, it was very big, about 2,000 um, Zambians, and now we're probably about half that, a little less than half that, through the 2025 yeah, challenges, I guess we'll call it politically challenges. So we've done a lot of work with PEPFAR. A lot of my funding comes through PEPFAR, CDC. Um, done some work with a lot of my work is in HIV, the non-communicable disease comorbidity space. And I just wanted to give the nod that if you do want to be global health researcher, it often can take some time to set those foundations. And in my experience, again, just pretend that caveat is in front of everything. Um, there's no substitute for time, for just being there day in and day out. I mean, I think one of the main reasons that I am still with CIDRS and still welcome at CIDRS is, um, if you just show up day in and day out, people start to count on you and ask you to do things because you're going to be around. So part of that just and again, lots of you probably have maybe have already figured this out. So yeah, PhD was a big piece of getting to do what I wanted to do. I like working with the Ministry of Health in Zambia. The work that I get to do feels super fulfilling for me. And you know, it it again just there's many paths to success and trajectories may look different. And I think if I can recall, a few years ago when I kind of was on the other side of this, wanted to know what the formula was for success, and I want to work in global health. I like this. I've got some funding, but would like more. How do I make this a clear path? And uh, again, I'll just say that I don't think there is a hard and fast formula. There are many paths through F mechanisms and NIH to KO1 awards, KO2, KL2, through institutions. There's, opportunities with Gilead, with Johnson and Johnson, um, Gates, etc. And I think I may be a little bit atypical in that I didn't go through a lot of those NIH mechanisms as a PI, but kind of just tagged along as a co-investigator for a lot of things and ended up, kind of being able to cover my salary, and now get to be a PI and get to do all that fun stuff. But early on was told, oh, you have to get a grant, you have to get a grant, you have to get a grant, and you have to be an independent researcher. Um, that's probably the fastest way, but not the only way to be successful in global health, because that was not me. I just got piecemeal effort from, across 5 or 6 grants, and carried myself that way. And then also sprinkled in some teaching as well. Um, so a little bit more of the, kind of origin story, backstory. This was 2020 was right after I had finished my PhD. I did a year of postdoc, and then COVID happened. And I worked a little bit in California. That's sort of how I reconnected to Davis, because I lived in Zambia. I moved back in 2017, or end of 2016, to finish my dissertation there, and then stayed until 2020. Went back and became an instructor for UC Davis in 2021, and then did assistant professor, and now kind of getting to teach lots of classes. I have noticed that even though teaching I don't feel like is my strong suit, it's a really valuable thing. We're going to mention later something that you all I know are very familiar with too: capacity building. Being able to teach methods and approaches is really valuable, I think, to capacity building, which is um, something we probably need to pay a lot more attention to than we actually do. Um, so stayed involved with CIDRs even when I was back in California working with the California Department of Public Health as a senior epidemiologist. We got to do some really cool work. Like Dr. J mentioned, I got to do stuff with mask effectiveness and vaccine effectiveness. And we wrote one of the first papers out of California Department of Public Health that was, "Hey, masks work." So I've got to be part of some really neat work, that some research that normally doesn't get to originate in a public health department. So that was it was a really unique opportunity, and I think they've since sort of a lot of that funding has sort of been spent down. But it was a really neat time, even though it was, of course, very horrible, difficult, awful for a lot of folks. COVID for epidemiologists, for those in the health profession, had huge impacts on both sides, positive and negative for sure. And giving a nod that it was a very tragic time for a lot of folks. So don't want to minimize that at all. Um, so now I get to be part of this team in CIDRs, or now I split time kind of between the University of California, Davis, the School of Medicine there, and CIDRs, the Center for Infectious Disease Research in Zambia. So that whole go deep to go wide thing worked in the end. I did most of my work on HIV. I did some work with the chronic kidney disease of unknown etiology in Sri Lanka. Got a little grant to go and look at that stuff. But now get to work with lots of different conditions, right? Got to do work with cervical cancer, some cholera stuff. We were looking at using a patient health questionnaire, the 9-item patient health questionnaire PHQ-9, to identify depression among folks, HIV healthcare workers. Just like my little soapbox moment to, um, I think you're all here, but this whole philosophy of figure it out is really important, or as they say in some places, in on the continent, the make a plan, figure it out, make a plan, adapt, right? This is my method to get through a lot of different scenarios. It's really simple and silly in a lot of ways, but it if you're willing to do this, to put the time in and talk to others, iterate and figure it out, that will get you most of the way, I'd say. And then, of course, I think in global health, different. I say global, I mean, like my work in Zambia um, is very different than work in Davis, or in School of Medicine, where we have specialists for everything. Every niche has a specialist, and you've got somebody that can do all of it to the nth. There's people that can do something better than me on almost all things at Davis, right? Um, in in Zambia, it is very valuable that I'm not just a niche specialist in one thing, but can do multiple things. Can go from talking about budgets to talk about implementation science, to talk about methods for analysis, to talk about how to fix a design that has gone off the rails. Um, you have to sort of wear multiple hats and do things that you would say are not technically, your job. I don't think I'm allowed to say that anymore. I'm not sure that you're allowed to say that as a global health person. Like that's not, it's kind of all your job. And we all have hopefully the same drive to make, quality of life, health outcomes better for folks all over the world. Um, so again, like just kind of focusing on like that, you are a specialist and you are an expert as a, terminal degree holding person. Um, and doing more than just that thing that you are really, really good at and trained really well to do is also important. I grew up on a farm in Texas. I found myself, repairing the diesel generator when it went down. That's not my job. I mean, it's kind of fun for me anyway, but I guess other than that, like you're going to do things sometimes that are just not your job. And if you're opposed to that, then global health, may not be the best fit. And, working in an academic setting when you can just focus on your thing in your box might be a better fit. I hope that's none of you. You're GloCal. Hopefully you've fallen in love with all this stuff too. But just wanted to give a nod to sort of some of these methods that I have employed to, I guess, be successful. It still sounds silly to say that, but to be successful in global health. Um, so I just kind of went through, like, here's some results. Um, it feels weird to have results without any numbers as a quantitative researcher, but here we go. We've got, travel. Hopefully you like travel. I will say travel is uh, gotten a little bit less fun maybe, and I blame COVID some, but still cool. Hopefully you still, get excited when you go into, get into a lounge. I mean, I've spent the night on enough airport floors to like now getting to go to a lounge feels like something super special. Um it, I can't really complain about my this split gig of being in Davis for, 3 months and being in Zambia for 9 months. And I can say that splitting time is difficult. Living in two places is impossible. Um, so, keeping up community in both places is a big challenge. I thought that this was, oh, of course, if I can just get to this point, I remember thinking like that, that's perfect. I think that's the right split. And while it's great, and I'm not a martyr by any means, it's still difficult to be in two places. So, um, just let folks know it. You often have that grass is greener, and then you get over there, and it may not be. So, just for what it's worth, you'll find yourself in the same position at some point, maybe, and get to see yourself. But then, yeah. So research. It's kind of what keeps me going. This is definitely my favorite piece of what I do. I really enjoy writing papers, and a lot of my work is using big data, routine data sets in Zambia, who is an early adopter for an electronic HIV medical record. I love asking research questions of that big data set, working with Ministry of Health folks and CITRS folks to, you know, analyze that data and tell stories about, hey, 6 month refill is better than 3 month refill. Is 12 month refill better than 6 month refill? Maybe not, and looking at suppression outcomes and who is the cascade working for, who is it not working for, and what can we do? That's my favorite. So grant writing is going to be necessarily be a piece of your world probably. Whether you want to be PI or you want to just contribute is sort of up to you. I think you can do both. It is valuable to be a PI and to have that sort of I would say security, although this year that sounds really silly again. So getting comfortable with at least writing and being able to write scientifically is really important. Teaching, again, not really my favorite, but when someone does decide, oh yeah, I thought I hated epi and I don't hate epi anymore. That's nice to hear. Um, I'll talk about. I have an ode to balance here. I have in no way model that. But it's also because I really love what I do. It's that work to live, live to work kind of thing. If you work to live, then maybe industry is the right space because it gives you, you know, um, that kind of capacity to really do whatever you want when you're not working. I kind of fall in that live to work. I love what I do so much that like it's what I do most of the time. Um, Again, not billing this as a healthy approach, but just a reality. So, and then I think I mentioned adaptation. If you don't, I think I remember going over to Zambia the first time. It took me way too long to stop. It wasn't until like 6 months in, I think that's what I mean by way too long. Um, before I stopped trying to make my space look like what I was used to in this, like in California or Texas, and to just say, "Oh yeah, I'm here now. I should do things a different way," and recognizing that there are many ways to do a thing to accomplish a task, a goal, is really valuable. I think it was for me. And then capacity building, I don't, yeah, I don't have any one-liners for this. It's really difficult, and we rarely give enough time or allowed enough time to do this well, I think. Um, doesn't mean that it's any less important or valuable, and doesn't mean that, you know, the funders don't want to see it, but I think it's rarely understood how much time and money it takes to do this well, to capacity build well. So that was, kind of my realization as well. And I kind of wanted to go through some of my, we'll do a discussion. I wanted to go through some of my research quickly because I mean, I love it and I hope you love it too. So gonna go through some of that. Been in Zambia for a long time now. Been in and out, but physically there for 10 years. Then to talk about funding a little bit. I've had a mosaic of funders from Gates and Davis. Has lots of institutional grants. NIH. I work on probably 10 different NIH just as a co-investigator on 8 of them. And just piece together some of that work from, looking at what happens with suppression while people are incarcerated or after they're released. Um, the CDC still has funding. CDC Zambia is still around. They want to know whether or not that thing I mentioned about 12-month HIV refills, is that useful? We've got some private donors like Johnson and Johnson and Gilead and those as well. So there's still lots of places to get funding. The competition and that landscape has, of course, changed a bit, but there are still options. And I think that there are some new players here too. I just mentioned a few, but I think that the massive changes that are happening right now um, at NIH and really just nationally in the U.S. Are kind of facilitating some other funders popping up. Also, just a quick plug for Zambia. These are some of the great people that I work with. There's also great climbing. I love climbing. There's some really cool stuff in Zambia. So just come to Zambia. It's pretty great. I know there's lots of places like this, but this is yeah, some of why I really love where I am. And then of course the research. Like this is my favorite part. So I've gotten to work across quite a few different spaces, stuff that I didn't think that I would be into, and actually am. And in addition to some stuff that I knew I loved, and get to continue working with at a different, kind of to a different degree. So we did this really cool work. This was Johnson& Johnson work. Basically wanted to, and I'm an epidemiologist, so I'm going to ask, what is the question? Like that's kind of our mantra, our go-to. Yeah, like what is the question? So our question here with this Johnson& Johnson work was, does whether or not someone took up the COVID vaccine have any impact on their intention to receive a new novel vaccine? As we're sort of now on the cusp of hopefully a new TB vaccine or even HIV vaccine. And we've got, some things in the pipeline that are in exciting places, and just trying to see if there's any lessons that we need to be kind of paying attention to with regard to the COVID rollout that may inform novel vaccines going forward. Um, and it was, I mean, I think it was pretty interesting. Um, oh, sorry, this is got a little slide order issue. I'm going to pop ahead here. So we had this really cool design, I think, um, to go and knock on doors. We went to 4 different communities and knocked on doors and asked folks, where they were. This is I think, a really neat design because it doesn't require any level of health-seeking behavior. Um, Going to the people, you have a really cool cross section and a really great capacity to talk about what's going on in the general population. Um, as opposed to when maybe just catch them when they come to a clinic or they come in for COVID testing or something like that. So we employed some of these healthcare workers. They went out and delivered this survey, and we found that COVID vaccine uptake has very little to do with whether or not somebody is willing to take up a novel or new vaccine. We split this into A and B here, where A is the community members. We had about 395 of those, and B is healthcare workers. We had 104 of those. Um, so you can see the only thing that was associated or significantly different across that blue no COVID vaccine, red one vaccine, one COVID vaccine dose, and that green two COVID vaccine doses um, is a novel COVID vaccine. So we looked across these seven pathogens: influenza, pneumonia, novel COVID, TB, diarrheal illness, malaria, HIV. Um, and you can see the only one here is this, they're significantly different. Those that had no COVID vaccine were the least, had the lowest probability of novel COVID. See that influenza, not a folks getting super excited about that one. TB though, malaria, HIV, those are the ones that folks could get psyched about. I see just wide confidence bands on the healthcare workers, especially for no COVID vaccine. This is a good thing. There were few observations of healthcare workers that did not have COVID vaccine, so we've got really wide confidence intervals here. Um, and we kind of see a different shape even here. Again, it's an ode to low numbers, but we do see, the 1 and 2 doses. Do see that those that had kind of that dose, we see this dose response where we got one dose, lower probability than those that got two or more doses. So, just that what we see sort of in the States, there are people that really love vaccines. There are people that, approach them a little bit differently or have their reservations or confidence, suspicions. So um, this was really neat. We got to do this with a great team and got to do some capacity building for how to basically run this little a pretty shoestring budget grant and get some neat stuff out of it. I think we have 4 or 5 papers coming out of this little bit of work, which is really fun. I'm going to go back to this other question on a loss of suppression. We did this with a group of incarcerated people in Zambia. And just the question was simply, is hazardous alcohol consumption related to loss of viral suppression among those being released from incarceration? So, I mean, the clue is in the hazardous piece, I think, right? And so our spoiler is yes. There is an association between hazardous alcohol use and loss of suppression. Um, Quite a big one here. This was just published a couple weeks ago in JANA Network Open. We have this, adjusted rate ratio here for those that do have unhealthy alcohol use as identified by the Audit C. That those of you that are familiar with that, and so I mean, this is again not necessarily groundbreaking stuff, but a lot of what I've done. I mean, neither was masks work during COVID. A lot of the work that I've ended up doing is kind of but I would say common sense is not the right word, but is not necessarily novel. Or not proving that lenacapavir is amazing, which is an important work, but not getting to get to do that as much as just say, hey, we think that this is the case. Let's just provide the evidence for it, right? Following up with people that are previously incarcerated after incarceration to understand their suppression status is really difficult. So this is a small number, small n for the most part, but as you can imagine, attrition for keeping up with folks after release is difficult. Um, then just a quick nod to prep, and this is being undone. We got Dr. Kumar, Ramya, my great postdoc, is on the call working with some of this stuff as well. So the dreams houses were a really great safe space where young people, especially young women, were engaging to receive. And Dr. J, you're in this space too, prep stuff. So dreams houses are I think they're some of them are still around in Lusaka. They look a bit different. The funding has changed, of course. Even some of the resources may or may not still be available. But we kind of took a look at this to see if they were actually doing what we hoped that they were doing, and that is kind of keeping people on prep, that start initiate prep on prep, and which is also a kind of an interesting philosophical question for me. But because it's not the prep is a little different than ART, which is antiretroviral therapy. Once you start ART, we want you to always be on ART. With prep, your need for prep may change over time, where ART doesn't. So it's an interesting space to be for sure. But we wanted to see, all right, dreams houses, do they work? Do those that kind of initiate tend to continue? And the answer is kind of mostly. So this is time to refill. I mean, see about after 90 days or so, we've got about 65% coming back that are in that 20 plus group. The younger group, 15 to 19, don't come back quite as readily or to the same degree or magnitude. So we got to do some of this work with a great team, including Ramya and Maurice Macheke with CIDRs. Then quickly to make sure I'm not running out of time here. But we did some work with patient-centered care or person-centered care. This, I didn't. This doesn't sound like a big deal, but that third bullet here, we really just wanted to test what is it like to, when healthcare workers are nice. Lots of times, healthcare workers assume a sort of parental role where there's a model to sort of reprimand people that have been out of care when they come back to care because that's unsafe and unhealthy. So we, and Elvin Gang, really great researcher, had done some work on why people are lost to follow up, and some people are lost to follow up because they were scared of going back to the clinic to receive the inevitable, what they called punishment visit for having been out of care. So enter PCC to try and support healthcare workers who are in an overburdened setting and have lots of reasons to respond the way that they do, trying to support them to adopt a different sort of norm or culture for care. So the proposed outcome for this was viral suppression. We thought, okay, you get nicer, you have a nicer healthcare staff, you engage with the clinic, you're more likely to stay in the clinic, and then more likely to be suppressed. That was really probably a little bit too distal um, to look at. What we did see is that reports of rude behavior did go down significantly. To say that less rude behavior results in more suppression or higher levels of suppression is tough, because viral suppression is already very high in Zambia, which is great, right? But we had a very small window in which to kind of improve. So if suppression is already at 92 or 93%, you can only improve it that 7%. So we did see that, among those that were maybe the most vulnerable, we did this it's a quintile regression analysis, that those that were, had received sort of the poorest care, PCC had the biggest impact, unsurprisingly, but they're also a smaller proportion of the population. So we're kind of aiming at the tails, if you will, with this. But it was really great work, and we're still answering questions of that big data set. Um, so that's some of the research. You're a GloCal fellow. You know all of a lot of this stuff. You've now got some experience in an international setting, or you've been doing it for a long time. I think finding what you can be passionate about, what you dig, is a lot of the battle, and being successful and just enjoying what you do. Um, I think that this third bullet here, the balance between doing what you want, autonomy and compensation, it's not direct, but I know that I have been very willing to sacrifice that compensation any day to do what I want. And so, that maybe that is part of the narcissism or ego or whatever it is, but I would really just love to do what I want, and as long as I can survive, I'm good. Now, there's people that have figured this out and can do both. My hat's off to them. That's awesome. And maybe some of you've already figured this out. You should be giving this talk. But oftentimes, I think this is sort of a balance that you need to strike. Um, and then again, just another ode to a little nod to funding. Continues to be tricky. My strategy's been, this mosaic, where you can kind of have a sliding scale where, all right, right now I only need 10% from this, but I may need to move that to 20 or 30%, depending on what happens. Being involved, being familiar, and this is goofy, but playing nice with everyone is really important. We collaborate pretty. I mean, there are very few folks that you can't make an enemy and not see them again. I mean, like you want to play nice, you want to be collaborative, you want to be somebody that people want to work with. You want to offer a skill set and an attitude that is appealing to folks. And unless you can do that independent PI stuff and you can kind of be on your own island. Team science uh, sounds really good, and in practice, I have found can be tricky, difficult. It can be great as well. I should say that. Got a few people that I work with that are just lovely, wonderful, um, and include me on all kinds of stuff. So that's it. And then be open to iteration. I think in global health, it's we have to set aside some of that ego from time to time and be told things that you already know. At least again, this is for me. And we've kind of in the West been told, don't endure mansplaining, don't do the and don't endure volunteer work and all of that. I don't think that perfectly mirrors some global health work. As much as you can get paid for your work, understanding that there may or may not be funding for what you want to do all the time. Um, doing things that are kind of say below you, but that somebody with less training could do. Um, I guess I can just say I have done that quite often, and it does lend kind of street cred, and of course, then ingratiates you to the groups that you work with, because it usually doesn't go unnoticed that you're kind of doing the grind. Then I just wanted to pitch really quickly your own GloCal, but this group ZERP that I mentioned or RZERG is also great. So there's some contact information for them if anybody wants to get in touch with them. And I will leave room for questions here. Hopefully that touched on some of the stuff you wanted, but I'll be quiet and see if anybody has things to say or questions. Thanks.
Jake, that was great. Thank you for sharing. I love the fact that you made the presentation like a research paper. And I loved how you navigated your career, with the methods and the results. And I think a lot of the things that you mentioned is really important and it resonates with me as well as with our trainees. I think in this field, like your point about finding something that you really enjoy doing, I think that's really critical. And then in the current climate, you also need to be very adaptable and kind of evolve in terms of seeking different opportunities and not really, set on a concrete way to do things, but how you approach your work, you have to be really open-minded and flexible. So I really value your experience and I really appreciate it. So thanks. And I think let's see, Jackie has a comment or question. Go ahead.
Mhm. Yes, thank you so much, Dr. Price. This has been very insightful. Actually, the actual word for me is liberating. Especially as just some of your comments around there are many ways to be successful in global health. And I think I'm at that juncture in my journey where I finished my PhD. I've been running a nonprofit that I started, and so I've been getting all these questions around, you gotta choose one path. You can't be in both places. And I've not kind of had, I love research, there's no question. So I also loved how you talked about knowing what you love. And I also enjoy writing papers and like learning through that process. So so I think I just wanted to say thank you for that statement, and for me it's liberating to kind of sit with that still, because my research also builds from my nonprofit work, and it's purely centered on what I'm doing in the nonprofit work. And so I've just been trying to figure out like how do I, as I move forward, marry that in like a more robust research kind of plan and practice. So thank you for that. I also loved your comment around go deep to go wide. I've not heard it before,
Yeah.
but I appreciated it because in my work, I focus on widowed women as a subpopulation. And when I got into the work, it was more of seeing how many of them experience high prevalence of HIV in a lot of work that was already published, but then that's where it was stopping. There was no, what is the next question around why and what are we doing about that? So for me, that's kind of what I've picked in my work. And as I've been going deep in that with this group, there's so much things that are coming up. I'm like, oh my gosh, like this is so wide than I could have thought about. So I feel like I have so much learning. Of course, my mentors have just said that there's so much building from my PhD and the work I'm doing now in GloCal fellowship. There's just a lot of things to learn. So I appreciate that. So I have or I have two questions. So the first one, you talked about how like you've seen people have, you use the word unlikely success, like they didn't follow what we expected to be. This is the traditional path to succeed in research in global health, but they still succeeded. I would have loved to hear more examples of that, just to kind of continue expanding my thinking around the different pathways that are there, and that we can build on. And then the second thing, conferences, when we go to conferences to present our work, have you, in your experience, used that also as a way of connecting to new funders or raising funds for your research and thinking of, so what practices have you done around that to use also conferences as a way of making connections? I really liked seeing the wide kind of array of different funders that you've worked with over time. But thank you so much.
Yeah, thank you so much, Jackie. Those are great questions. I would love to talk for a long time about your nonprofit. That sounds super interesting. Um, but kind of tackling your first question first, the untraditional paths to global health success and work. And I think you know, uh, I mentioned that I'm not, didn't start as, an F grant to go to a K grant to go to an R, right? That's kind of the sort of usual path. And I've seen people just jump straight to an R before, or I mean, honestly, avoid NIH funding altogether and be very successful. Um, it can be tricky. I've got one of my colleagues, Joe Lunard, who I think he was, I mean, he's brilliant, right? Just he's at Berkeley. I think he had tenure and like associate professor by the time he was 29. He's, unreal. And he never had an NIH grant. He is never an independent NIH researcher. He had funding from lots of private groups and through institutional support from Berkeley. He is an incredible researcher, has done some amazing work, and has not been through that NIH mill, I guess. And so he's a great example of that. I've got other folks that have started in academia, gotten an NIHK and realized that they wanted more balance and just bailed. Right now, one of my friends, Monica Roy, is an MD. She did her K, and then she just said, "This isn't for me," and went over. And now she's at Santa Clara County in California, enjoying being a health officer. I think that is success and is probably making 3 times what she would as an academic. Um, you know, so it's really that I guess once you find what you want or what the balance that you want to strike, there are ways to get there outside of the usual. I mean, I guess what I mean is success generally, right? So we usually think of success in that academic structure. Um, and just that there are more ways to look at it than that. If success may be doing what you want, and that may not be what academia is cut out for. It may be getting to help people and getting to see that one on one and getting to interface with folks. That may be more that kind of government or NGO level or space. Um, those are at least a couple of folks that I can think. There's also somebody that I was one of Elvin's trainees as well, Mega. She was in academia for a second. She went over to California Department of Public Health with me and is now at Gilead, and loves it and gets to write papers and gets to exercise some research. She's typically, she's not a PI, and um, I have joked with her like, "Hey, Gilead seems pretty cool. Can you get me a job?" And she just looked right at me and said, "I could, and you would hate it because people would tell you what to do." And she's totally right. I don't respond well to that at all. So, I know myself, and she knows me well enough to say like, yeah, it's not, um, this wouldn't be a good fit. Um, so talking to folks that are in those different places as much as you can, ideally if they know you well too, to say like, yeah, this is not Jake. That won't work. Jackie, that's not a good fit because you want to do things like this. Um, so that that's a few examples of that untraditional or atypical path, if you will, to what we'll call career success outside of academia maybe. And then conferences, also good question. Um, I mean, I love IAS because their swag is pretty good. I'm joking, of course, but like there are some neat opportunities to just interface with people, and sometimes just I guess I can advise. I've gotten only like a couple of meaningful contacts at conferences. So I guess I say my hit rate, my success rate, is probably suboptimal for networking at conferences. And typically, I only go if I've got something to present. Um, but you out of the fistful of 30 business cards that you get or contacts that you make, maybe one or two has some traction or has. So it's a lot of effort. It's not to discourage you from making the effort. It's definitely useful. Um, and chatting with folks and seeing what they're doing is sometimes just nice because there's entire companies that are in spaces that I thought were secret, and getting to understand um, exactly, and this is not the best way to, exactly how saturated spaces are can be helpful as well. Are there opportunities? Where are the gaps? Because we are always thinking about gaps as researchers, right? Like, you may find that what you thought was a gap is not at all through some of those contacts with folks. So that's how conferences have been useful to me um, from a professional perspective. And then I actually really just love walking around posters as well. So there's the whole vendor setup and all of that, but walking around posters and you know chatting with the folks that are doing stuff that you think is interesting has been usually is usually more helpful to me to find collaborators than to find funders, even though that there can be overlap there, right? But yeah, so hopefully that is at least
Yeah.
semi-satisfying answers to those questions. Thanks, Jackie. Yeah, Jake,
Yeah,
go ahead.
that was a great suggestion, and I'm monitoring our time. I think we still have at least 9 or 10 minutes or so. I just wanted to share that I'm currently on the Dissemination and Implementation Science post conference with our funder, and one of the keynote speakers. I mean, the beginning speaker was Dr. Jerry Dunnenberg. So she's the current Office of AIDS Research Director. And I think one thing that's really clear is that, and Jake, you mentioned this, that the climate of NIH funding is rapidly changing, and the way they fund grants, including the global research portfolio, it's changing quite a bit. but one thing for sure is that they really prioritize the area of implementation science. So they did like the scoping review of all the funded research that was supported by NIH, and they said, you know, studies that were framed in implementation science was severely underfunded. So, you know, that kind of shows opportunity in terms of presenting or, you know, creating more investigator-initiated research projects that are framed around implementation science. So I think the take-home message is, you know, we have to be mindful of how the field is changing, including the NIH. And NIH used to have like a notice of funding opportunities or, you know, notice of special interest, NOCI or NOFO. So she informed us that they're going away with that, and they're going to have this thing called program highlights, where they'll just identify these are some of the areas that NIH has priority. And it's up to each of you investigators to propose investigator initiated research projects. So I think this is an example of changing climate, the way funding decisions are made, but at the same time, we can kind of think of it as an opportunity to really, you know, kind of adapt to how we interact with NIH. And I think to Jake's point, we have to be diversifying our funding opportunities, so including like pharmaceutical companies and other organizations. So yeah, great discussion. And I know that there was a colleague, I think PK had James had a hand up, I believe.
Yes, Jay, thank you. You've really partly touched what I wanted to ask, the guidance on the NIH funding. Mine was to Jake, about the, you said, spread across different or multiple groups. When do you realize that you are spreading too thin?
Yeah. Excellent question. Thanks for that, PK. Oh, hopefully it's, yeah, sorry, I think it skipped for a second. Hopefully that's not my connection. Yeah, great question, PK. I think because this is a very real kind of limitation that we do need to think about when you're juggling a array or a mosaic of funding streams and working with multiple collaborators. I imagine, PK, you have some standard for your work. You know, when you have a deliverable, and you know you need to complete an analysis, you need to design a study, you need to review a protocol, you need to. I think I recognize when I'm not able to do that up to my standard. Um, I need to pull back because doing things in a suboptimal or substandard way isn't really fair to anybody, and you know will is a reputational threat to me if I don't get out the products that I think are at the quality that they ought to be. um, and so recognizing sort of those limitations, and hey, I've got this deliverable, I've got this deadline, and I can't meet it with a product that I like, that yeah, I've been able to iterate and get to my standard. As soon as you run out of time to do things to your standard, when you've been wise with time otherwise, that's when I decide, okay, I need to pare down, which of the current portfolio items can I do well, and which ones do I need to like let go or say, hey, I need a break for a little while. I can't demands right now, my priorities are XYZ, and I may not be able to get to this ABC in the time that I wanted to. But I think that the easy and slightly cliche answer, if you guys communicate, it's all communication. If you think you're able to do it but need more time, then excuse me, then ask for that time and say why. But just recognizing your standard and what you can do well and when you can't. That's really the main thing, I think, because it's sort of internal and take some iteration and just introspection, which is sometimes not everybody's favorite thing to do, but nonetheless critical. Thanks for that question.
Great. All right. Let's see. What time are we at? So we got like 4 more minutes. We want to make sure we end in time. Any parting reflections or questions for Jake? If not, then I want to make sure that either Kimberly or Julie, if you have any announcements for our trainees. Okay, so we got one more. Go ahead, Nelson.
So Jack, thank you so much. I don't know if you can hear me.
Yeah, we
All
can hear.
right. Thank you so much for this talk. I learned a lot to navigate your story, how you navigate this two words, and yeah, the success that you are having. My question is regarding to one thing that you talked about, like sometime, you have to go to the direction of the funders, because maybe you want to do something, but there's no someone to fund it. So how do you navigate this reality? I think, yeah, especially when you are at the beginning of your career. We are lucky with the GloCal because we came up with our own research interests, and we were able to have this this to be part of this program. But I don't know, how to navigate afterwards. Yeah, especially with this rapid changing in terms of the financial landscape.
Yeah, Nelson, great question. I guess the quick answer is nights and weekends. I one of the things that I am thankful that I have been able to do and been given bandwidth to do at Siders, I'll just give this as an example. The stuff we've got data and I can play with that. So what I'm funded to do is over here. But typically, if I see something and I can put it together, I can nights and weekends make a story out of, so silent transfer is something that's very near and dear to me. I think silent transfer of care, that is when somebody is engaged in care and then they turn up at another facility and don't disclose that they've previously been in care. They're a silent transfer. So they look like they're lost to follow up over here and they're a new client over here. That wasn't on the radar until I started playing with it and get to show data. I'm like, hey, here's this thing. I think that this is really important, and started, shouting about it from my little box. And CDC was like, oh, we agree. That's really important. So do you want money to do that? And yes, you do. So sometimes it's a sort of cart and horse, chicken and egg kind of question. You can be interested in something and want to do research in it. It is very helpful, at least in my experience, if you can grab some data, make the case that it is important and is a space that needs to be supported, and go with something in hand to say, like, I've looked at this, it's a big deal. Here's the impact that it could have. What do you think? And just talking about it with everyone that you can find, especially folks in that space. I think there's people that are worried about sharing because they're going to get their idea stolen or whatever, this or that. In my group, I'm fortunate enough to say that everyone only wants everyone to do well. We're all interested in the same thing, which is pushing science and improving health. But great question. Thanks, Nelson.
That's great. So I think we're at time.